Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello, thank you for joining us for Clinical Clips in Acute Myeloid Leukemia, Key Updates and Breakthroughs from ASH 2024. My name is Dr. Naval Davar. I am Director of the Leukemia Research Alliance Program and Professor of Medicine at the MD Anderson Cancer Center in Houston, Texas. In this clinical clip, I will highlight key data presented at the 66th American Society of Hematology annual meeting in San Diego, California. So at this meeting, there were a number of updates on various drugs being used in acute myeloid leukemia, including available drugs as well as emerging therapies such as venetoclax, FLT3 inhibitors, IDH inhibitors, menin inhibitors, antibody drug conjugates, new bispecific antibodies, as well as other cellular therapies. Many of these were presented also in combinations with different established standard of care acute myeloid leukemia regimens. I'm going to start the discussion first discussing what I thought was one of the most exciting and interesting topics, I think not just for me, but in general for the acute myeloid leukemia field, which is the menin inhibitors. This is a third potential group of targeted therapeutics emerging in AML. We already have the FLT3 inhibitors that have really improved the outcomes for FLT3 mutated AML, especially once they have moved into the frontline setting in combinations, both with intensive chemo and with HMA-VEN. IDH inhibitors similarly improving outcomes quite a bit in combination approaches, both in salvage and potentially now into the frontline setting. And now we have this new group of targeted therapies that targets a third group of mutational subsets, including the NPM1 mutated and the KMT2A rearranged patient population. So the development of the menin inhibitor started about 4 to 5 years ago. The first one was a drug called revumenib, which has recently actually gotten FDA approval just about 2 months ago for relapsed refractory KMT2A rearranged acute myeloid leukemia. This is the first official approval of the menin inhibitors, which is very exciting. So let's start with some of the data that was presented. One of the key data sets was the update of the Augment 101 study. This is a phase 2 study looking at revumenib in all patients with relapsed refractory KMT2A rearranged AML. This was presented by Dr. Ibrahim Aldoss from City of Hope in the menin oral session at the ASH meeting. Basically, what Dr. Aldoss showed was that the CR/CRh rate with this combination was about 22-23%. This is very similar to what has been shown in the previous phase 1 publication in Nature by Dr. Gus Issa, where the CR/CRh rate was again about 23-24% for relapsed refractory KMT2A rearranged. The duration of response here was about 6 months in the relapsed refractory KMT2A rearranged on this updated presentation of the Augment 101. This is also in line with what has been shown with other menin inhibitors. From a safety perspective, I will say revumenib has, in general, quite a manageable differentiation syndrome profile. We have used this drug in many patients here at MD Anderson, and yes, we do see differentiation syndrome, especially in the form of leukocytosis, sometimes with some pneumonitis and pulmonary inflammation, but in general, differentiation has been very manageable with awareness and intervention with steroids and hydrea for a few days. This is different from some of the other menin inhibitors, especially ziftomenib and bleximenib, where we have encountered a more severe and earlier, as well as in some cases, unpredictable differentiation syndrome, which again, we are getting better at managing, but does require a little bit more close surveillance and aggressive intervention. So I think this is one of the benefits to revumenib, which I think the FDA appreciated as well. Now, that being said, we do have QTc prolongation with revumenib. This is something that has been seen with the grade 3 rates between 13 to 15% across the phase 1 and the registration study. It is manageable. We have not seen high frequency of significant clinical cardiac events. But we have to take into consideration that these grade 3 QTs rates of 13 to 15% were in controlled clinical trial settings with all of the checks and balances, including avoiding major QT prolonging drugs. So as this drug is now approved, it will be important in the community setting to try and continue the education to avoid using significant QT prolonging drugs. Otherwise, I am worried that that QTC prolonging signal could lead to complications and cardiac events, which we, of course, want to avoid. But all in all, good data. This is basically the update of the registration that was secured a few months ago, and we are now looking forward to more data in the relapsed refractory NPM1 subset from revumenib, which was also as a press release a couple of months ago, and I think that also will hopefully move forward to the FDA review in the next year. Now, the next single agent I'll discuss is a drug called enzomenib. This is actually the drug that came later among the four menin inhibitors. So it was first revumenib, then ziftomenib, then Blexi, then enzomenib. And Dr. Zeidner presented some of the updated data from the ongoing dose escalation, dose finding phase 1b. Overall, we had 40 patients treated at the doses that are being evaluated for the RP2D, which were basically 200 BID and 300 BID. And we showed that the CR/CRh rate with this at these dose levels was actually quite encouraging in the KMT2 area range. It was about 35% CR/CRh, and in the NPM1 relapse refractory, it was actually 47%. And this is quite a relapse population, median salvage 3, about 85% with prior venetoclax, 40% with prior transplant. So again, it's hard to compare across trials, but definitely looks like a encouraging and robust CR/CRh rate, overall response rate about 55 or so percent. And then from a safety point of view, we had a total of about 80 patients across the entire study at all dose levels. And more than efficacy, which I think, again, is hard to compare across studies, I think the safety of this agent is what has been encouraging to us. We, of course, have been using it for the last 2 years, along with all the other menin inhibitors at MD Anderson. And we saw that with this agent, the differentiation syndrome, again, kind of similar to revumenib, does occur, but is quite manageable with good awareness, early steroid and hydria use, and in most cases did not result in severe events. In fact, we had no ICU events or discontinuations or mortalities across 80 plus patients due to differentiation syndrome. Of course, the discussion there is what is the reason for this? Is this because the drug has a different structure, lipophilicity, binding, shorter half-life? These are all true, and this was mentioned by Josh, and I think that is part of it, but I think there's a second part of it, which is actually better awareness and management, because when enzomenib entered the clinical setting, we already had knowledge of other menin inhibitors, how to approach differentiation syndrome and manage it early and mitigate it. And I think it's a combination of potential drug properties, short half-life, which is very, very, very critical nowadays in AML development, especially with many patients being on azoles and other concomitant medications, as well as better awareness, early monitoring, early intervention, and has led to a much better safety profile. The other advantage so far with enzomenib is that we have not seen QT prolongation. So I think that is why safety-wise, this drug is, I think, in a very good position to move into combinations where, again, that short half-life and lack of interaction with azoles is probably going to play an important role. The third agent that was upgraded as a single agent is bleximenib. This is also a potent menin inhibitor in a single agent in relapse refractory setting. The data was presented by Dr. Emma Searle from the UK. Overall, encouraging CR/CRh rates about 35% across the NPM1 KMT2A, and these seem to be having a good duration of around 6 to 8 months. They also did discuss the RP2D, which looks to be around 90 to 100 milligram BID and will be used in the further expansion studies. From a safety point of view, no QTC impact, which is great, and will be less of a difficulty in combining with other medications with low rates of QTC and DDIs. But the differentiation syndrome is definitely something with bleximenib, again, that even before ASH, we have been quite aware of. There was an FDA hold due to differentiation syndrome, including two fatality cases in the early days. Now, with a closer monitoring, ramp up dosing, early intervention, as well as protocolized management of the differentiation syndrome, introducing steroids, Hydrea, whenever the white count went above 10, this seems to be controlled. But I do think still we do have to keep a close eye on the differentiation syndrome is something that is more frequent with the Blexi and Zifto. Again, in combination setting, this may not be an issue because the cytotoxic combination component may suppress the clinical DS, but we do have to be aware, I think, as a single agent. So those were the updates. I think all three menin inhibitors are moving forward. Of course, revumenib is already approved. We know that both the enzomenib and the bleximenib are moving forward to expansion, potential even phase 2 pivotal single arm expansions in relapsed refractory KMT2 NPM1, and then all of them have moved into combinations. So for combination, I'm not going to spend too much time. I'm just going to give a few highlights. So to me, the most interesting and exciting data, and not just because it's from MD Anderson, because I think it is more mature data, is the SAVE study, which is the oral decitabine venetoclax revumenib presented by Dr. Gus Issa. This was, in fact, in the salvage setting. They had 26 patients with combination triple therapy showing a CR/CRI rate of about 60%, overall response rate of about 80%. So if you look at this comparing to any of the single agent menin inhibitors, whether it is enzomenib, bleximenib, or revumenib, it is almost numerically doubling your overall response rate and CR/CRI rate, which is, of course, very, very encouraging. And we were able to get about 40% of these patients to allogeneic stem cell transplant, which again, in a third salvage population, is much better than traditional historical contemporary outcomes where the transplant rate would be around 15% or so. We don't have mature survival data, but he did show 6-month survival data, which was looking at around 75-80%. Of course, we will need to see 1 and 2 year survival. But I do think based on even this early data, there is a lot of interest and inclination towards moving towards combination. And we believe that in the United States, at least, the future competition as well as comparisons between these menin inhibitors are likely to shift as of 2025 and onwards towards their combination data and outcomes rather than the single agent. And so, of course, we hope to see more data from the SAVE. The frontline cohort has been initiated at MD Anderson, and hopefully we will update that next year. There's also a frontline Beat AML that was not presented at ASH, but was shown at EHA earlier this year, where with 24 patients with the HMA-VEN revumenib, they are showing a overall response rate of almost 100%. Again, we don't have durability and myelosuppression data, but this looks quite promising. There was then also combination data with intensive chemo 7+3 with both ziftomenib and bleximenib. I think this data is going to be much more difficult to interpret in the landscape of what is the expected long-term survival with the intensive chemotherapy in these two subsets. And nonetheless, I do think for KMT2 arranged, a frontline combo of intensive chemo with menin inhibitor has a very, very high potential of being able to beat traditional intensive chemo and secure a new frontline registration. We at MD Anderson, Dr. Bologni at this ASH updated our CLIA venetoclax. So addition of venetoclax to backbone intensive chemo in NPM1 mutated, we had about 32 patients. And here the 3 to 5 year survival was close to 80%. So now we see that addition of either venetoclax, gemtuzumab, or quizartinib could be pulling the frontline intensive chemo NPM1 survival curve to 80 to 90%. So I think this is going to be a high bar. I know frontline studies are going with 3+7 menin, but I think one has to be very careful. I think the KMT2A subset is likely the one I would go after, where you're probably still looking globally at around a 50% 2 to 3 year survival that I think additional menin inhibitor could conclusively beat. And then lastly, I'll just mention that there were some other interesting phase 1 studies in relapsed refractory disease that were presented. One of them that I'm also involved with and I think is interesting, but I would use the word interesting, but it's too early really to know anything conclusively, was presented by Dr. Paul Montesinos looking at a immune approach engager called AFM28, which activates and engages CD123 positive leukemia cells with the T cells. He did show that sorry, with NK cells. So it's a CD123 NK engager. He did show that as a single agent at the current doses in escalation, we are starting to see about a 3 to 4 responders out of the 10 patients treated at the most recent dose level. Now, that's quite nice because this is a multiple relapse salvage 2 to 3 population. There's a single agent engager. It's not added with chemo. There's no conditioning. There's no venetoclax. So really the responses are all attributed to the therapy. Again, it's just 3 to 4 out of 10, which is why I think there's a word of caution. We've seen data like this with other NK cell-based therapies. So I think we want to see more mature data. But if we continue to see such responses in a 30% or more range, then of course, this could be one of the first immunotherapies in relapsed refractory AML to have a path, which has been a challenge and something we've worked on for the last 10 plus years. So I think interesting, but need more follow-up. And I think these were some of the key important takeaways, specifically from the menin field, in my opinion, at ASH. And thank you again for joining us for the clinical clips in acute myeloid leukemia, key updates and breakthroughs from ASH 2024. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access downloadable slides, as well as other topic segments and case scenarios. Thank you very much and have a great day.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.